Hello, everyone, and welcome to our interdisciplinary panel discussion on ethnic and racial disparities in pain management. I am Sheria Dotson, Student Affairs Program Manager for Recruitment and Outreach in the College of Pharmacy and the Chair of the 2022 MLK Health Sciences Committee. I am pleased to welcome you to our panel discussion today, where we will hear from several University of Michigan staff, faculty, and researchers and clinicians about this issue. Before we get started, I just wanted to share a few housekeeping notes with you. First off, this session is being recorded, so you will be able to access this at a later date on our MLK Health Sciences website, and the link to that website is in the chat. I'd also like to make sure that you know that that closed captioning has been enabled for this webinar, and it can be accessed by clicking the closed captioning button in your Zoom toolbar. And finally, we have compiled a set of resources that you can consult to learn more about this topic. And those resources will be placed in a link in the chat, as well as on our MLK Health Sciences website. And finally, the Q&A feature can be used, and we encourage you to share any questions that you have with us. We thanks to those who have already shared questions in the registration form. So we hope that we get to all of your questions, but please feel free to use the Q&A. And we also encourage you to use the chat to interact with each other and share any comments that you have. So with that, we will get started. And I will start by just giving a brief introduction of our panelists. So today we have Dr. Marcus Harris, who is representing Michigan Medicine, Dr. Mary Janevic, who represents the School of Public Health, Dr. Sheria Robinson Lane, representing the School of Nursing, and Dr. Michael Smith, representing the College of Pharmacy and Michigan Medicine. They will each, in that order, provide a more detailed introduction about what they do and how they are confronting this issue of discussion today. So starting with Marcus Harris.
Hi, I'm Marcus Harris. I'm currently a interventional pain management fellow at the University of Michigan. My background is anesthesiology, where I did completed my residency in anesthesiology, and now completing my fellowship here at University of Michigan. Different ways that I kind of combat this kind of in my field. It's a lot of different ways. One is, I think the first and foremost, patient advocacy. I think a lot of times, and we'll discuss this more with some of the questions, there's a lot of perceptions and a lot of beliefs and things that people have when it comes to patients of different demographics and how it regards to pain. So being able to kind of represent and communicate and kind of be that person who's an advocate for my patients is really one of the things I really push, especially during my time here at the University of Michigan. And the second thing I think that's big is education. I think there's a lot of things where there's things where people, it's not always where somebody's going out and it's something egregious or they are looking to do harm, but it's a lack of understanding. And so being able to, present my background where some of the people where there's some assumptions that are being made or some things that are being assumed, I'm able to kind of educate them on kind of, a demographic or different areas that might actually help them provide a better patient care for the patients that we see. So.
Okay. Should I go next? So I'm Dr. Mary Janevic from the School of Public Health, Department of Health Behavior, Health Education, and it's just wanted to thank the organizers. It's really an honor to be included as part of this discussion. That's a celebration of the life and legacy of Dr. Martin Luther King Jr. So I'm really grateful to the organizers for putting together a panel on this really important topic of racialized inequities in pain. And I'm excited to hear from my fellow panelists today and to learn from them. I'll give just a tiny bit of background about myself. So I'm a public health researcher. My training is all in public health and community health sciences and social epidemiology. So I don't have a clinical background, and I don't work in a clinical setting now, although I did work for some years as a health educator in a large healthcare system before going back to get my doctorate, because I wanted to do exactly what I'm doing now, which is conducting research in community settings in collaboration with community partners. So I'm getting to live my dream in that way. So I've always focused on older adults in my research, which has primarily been about how patients and families manage chronic illness and how they can best be supported in doing that, and especially within minoritized communities who have the heaviest burden of chronic disease and face the most obstacles to being able to effectively manage those chronic conditions. So the major focus of my current research program is inequities in chronic pain, and particularly on increasing access to psychosocial treatments for chronic pain among older adults from marginalized and minoritized populations. I'm especially interested in how community health workers can play a role in the pain care workforce and in addressing pain inequities. And so I might have a chance later today to talk a little bit more about community health workers and the research that we're doing. So for now, I'll just say for those of people listening who aren't familiar with the community health worker role, community health workers are lay health workers who are trusted members of the communities that they work in, and they really have a unique ability to form a bridge between communities and formal health and social services, and to see and address issues that are often invisible to outsiders. So I'm currently working on 2 large research studies of community health worker-led interventions within the Detroit community. Both studies have African-American older adults as the priority population, and one of them is particularly around pain self-management. So I'll stop there, but thank you again for having me and look forward to the discussion.
And good afternoon, all. Mary and I have quite a bit in common. We've been collaborators for several years now, doing pain research. I'm deeply interested in the older adult experience, and particularly how diverse older adults are able to age in place successfully with chronic diseases, and what are the things that help them to do that and the barriers to that. And one of the large barriers to aging in place is pain, both for older adults experiencing pain, which we know that there's an emotional and social relationship to pain, where it limits your ability to fully engage in social activities, to continue to do meaningful work, as well as there's a pain depressive cycle in which pain can influence depression, which can then have an effect on how cognitive status for older adults. So just having untreated pain can make you look like you have dementia, and or make your dementia worse. So all of those things are really interesting to me, both from the scientific study as well as the clinical perspective of what are the ways in which we can better educate individuals, particularly vulnerable populations who often have decreased access to effective pain management and treatment, and have a lot of social barriers and concerns around taking different sorts of pain medications. And then on the other side of that, for family caregivers who play a large part, particularly from individuals of minoritized backgrounds, of helping people to age in place for long-term in their homes. What happens when these individuals experience pain and then are not able to adequately assist in activities of daily living and other sorts of, the physical act of caring for someone. So these are the ways in which I am engaged in pain management research. And then I think clinically, as a registered nurse, you often get the community consults, if you will, where once people know that you're familiar with pain, I spend quite a bit of time talking with folks about their personal pain management needs and helping people to develop language around self-advocacy for themselves, particularly for different sorts of pain, like neuropathic pain, sciatica type pain, that interestingly, a lot of people don't necessarily view as pain, and sometimes they have a hard time talking with their providers about it and getting adequate pain management.
Good afternoon, everyone. My name is Mike Smith. I'm from pharmacy. So my angle on this is drugs, not only when we use them, but when we shouldn't use drugs. And so I specialize in pain and palliative care, and I run a training program for pharmacy residents doing the same. And so what we focus a lot on, and how I kind of interact with this space, is making sure that when we're selecting drugs, we're selecting them based on how that pain is presenting and how that pain is working within the body, and trying to really, truly individualize pain care by making sure whatever that drug is, it's matching up with that pain generator as best as possible. We've found, and what we know from the literature, is that pain responds best to mechanistic-based pain therapy. So when we're picking these drugs, as Dr. Robinson Lane mentioned, neuropathic pain, there's certain sets of drugs that work for certain neuropathic pains. We want to make sure that we're giving those drugs at appropriate doses and giving true trials. And that's my role in this, is making sure that when we select those drugs, we're doing it appropriately, and training kind of the next generation of pharmacists to be able to do this as well.
Excellent. Thank you all for your introductions. And I just want to remind our guests today to enter any questions that you have in the Q&A, and we will do our best to get to them. So I just want to start kind of just going back to some real basic principles. And so the first question is, what is pain, and how does it lend itself to the disparities that we see in the management of it?
Yeah, and I can jump in on this. And I think it's really important we all understand the definition of pain, because that's really where disparities start, is how pain has really been defined. The International for the Association for Study of Pain has recently put out a new definition in 2020. And that definition says that pain is an aversive sensory and emotional experience that's either typically caused by or resembling that caused by actual or potential tissue injury. And so some important words there is that this is an emotional experience, right? Everybody's emotions and their backgrounds are different, and that it can be caused by actual or potential tissue injury. We don't necessarily need tissue injury to have pain. And I think what IASP has done is put some specific notes under this definition that help us understand this better. So the first note that they have is pain is always a subjective experience. That in and of itself means that everybody's pain experience is completely different. But one of the things that they add on later is that a person's report of pain, their experience of that pain should be accepted as such and respected. And so that's, I think, a hard thing in the healthcare environment, where we have what we'll say one disease as pain that is so wildly different in every patient. But patients learn pain through their experiences, not just the physical damage, but the emotional damage, the social damage. And there's lots of data out there that shows that these disparities come from their emotional situations or their social situations. I'll give a brief example of one that I think might help set the stage. Is we know that ethnic minorities have higher reports of pain. But what's really interesting is studies that have looked at those minorities across different countries. Those reports don't always hold true. But what holds true is wherever they are, if they are the ethnic minority in that country or where they live, they report higher pain. So that tells you that there's a giant societal issue with how pain is accepted and perceived and received by those patients. And we all have different pain experiences. And I think that really what is one of the primary generators of this is that it is so different from every patient. You could have the same patient or two different patients come in with both fractures, and their pain experience is going to be very different and should be treated differently as well.
Just to piggyback on that a little bit, I think what Dr. Smith was saying about the subjective nature of pain. I mean, pain is a subjective experience, and it is what you think it is. If you feel that you're in pain, that is your level of pain. But I think it's that sort of invisible subjective nature that does make it particularly prone to bias, and to, certain groups systematically being not believed as much as others. So I think, pain does have some unique features that do make it particularly susceptible to inequities.
Yeah, and I agree with that too. It's somebody like you see it in the clinic, and I think one of the things that when you're going through medical school and doctors are getting trained, you know, like he said, he gave that definition of pain, and it was like exactly on point. Obviously, that's the definition that they put out there, and I agree. And so I think the one thing is like that aspect of it gets missed in the training. I think the big definition that gets learned in training is what we call nociception, which is defined as the neural process of encoding noxious stimuli, which, you know, so I think a lot of times that definition gets focused. And so a lot of times when I have patients, I tell them, first thing I tell them, a lot of times you see these guys, they come in, they'll look at an MRI and like, well, you know, your MRI looks fine. When somebody's in chronic pain, they don't want to hear you tell me, well, your image looks clean. I don't know. What I always tell, and when I'm teaching, you know, different doctors, especially with certain groups where they go through that kind of discrimination, that kind of bias is, you know, just because somebody's MRI looks clean doesn't mean they're not having the perception of pain. And just letting them know, like, I understand just because this looks clean, that's not the whole picture. I don't treat an MRI, I treat a patient. It's just the way going through medical school, the training, you learn these hard definitions. So if you don't see no pathology, right? Even when your tests, if they say, an example, they usually will have on our test, but they'll show us an MRI and the MRI is clean. Like with the patient, you expect the patient to have no, they literally have that on the definition. So it's like, oh, no pain. So it's almost the way you're kind of programmed in your learning and your training that certain things you see or certain things you assume, you know, not realizing that there's a lot of factors that go into somebody having pain, not just the necessary things that you can just see that are provided from the nociception aspect of it too. So.
And the last thing that I think that is important that Dr. Harris raises is how important it is for patients and families to be very descriptive about the ways in which pain is influencing your daily life, because that's what gets you some action, and they're required to write that down. So when you go and you say, I have pain and it's a level of 10, and to them, it's not observable that it's extreme pain, then it is presenting some spaces for bias. Versus when you go in and say, my pain is a level 10, I'm unable to work, I can't earn a living for my family, I'm not able to take a shower by myself, I require assistance, I'm only able to walk for short distances without a device. The more information that you're able to provide about how pain is affecting the different domains of your life and start with the physical, the more likely it is that one, they can get more data about what may be causing your pain and what the issue is around it to be able to effectively treat you. And then also, it gets it documented, you know, really well. And I think the other thing that we've had to come to terms with about pain management, particularly over the last few years, is I think that we've been misguided a bit in this idea that it's possible to be pain-free. And the reality is that for a lot of folks, that's really not an option. And so you really have to start to wrap your mind around what is the pain that I'm able to live with that allows me a decent quality of life. And so when we're thinking about pain management and treatment and like what works for you and the benefits versus the burdens of taking medication or doing something non-pharmacologically to manage your pain, you know, that's how you weigh it out is, okay, if I have small kids, maybe I can't afford to be knocked out in sleep, right? I have to have all my faculties because I need to know what's happening in my home, and I still got to be able to, you know, move around and get after this toddler. So I want to be able to do all of those things, and being able to have those sorts of conversations, I think, with your provider can also help to have more honest and open conversations about like what makes sense for you, and to talk about some of the side effects as to, you know, how, like, again, some of the burden that may come with, you know, pain treatment.
Well, I appreciate all of those comments. And Sheria, your comments about telling your provider how pain is impacting you and how it's influencing the things that you do on a daily basis was pretty powerful. And I'm wondering, to our clinic, or follow-up question to our clinicians, how often do you see that happening in the clinic? So Dr. Harris, Dr. Smith, Sheria, I don't know if you're seeing patients at this point, but I'm just wondering what would be the difference in a person actually getting a prescription that they might need to treat and manage their pain if they share that information, as opposed to sharing the number. I'm at a 10. Okay, I really don't believe you. I mean, have you seen that have a positive impact in your clinical practices?
Yeah, I think she's right on the head. And that's probably one of the things I actually do a lot, is educating, especially with medical students and residents and just colleagues, is this is part of your, as a clinician, these are the questions you need to be asking. My whole thing as a pain doctor is not to erase pain. It's not to get you to a zero. It's not going to be a zero. It's pain management. In the word, it's pain management. My goal for every patient is like, how can I increase functionality? The first thing I ask, one of my things I ask patients, what do you enjoy doing? I'll have a patient be like, I love cooking Sunday dinner. So I was like, okay, let's work on what we can do to help you so you can get to the point where you can get up and cook Sunday dinner for the family. It's those things and kind of relate. So a lot of it, I agree. You do need that. Is that going to help? Yes, because there's some, people that come in, if they hear a patient say a 10 out of 10, and you're sitting there and you're not writhing in pain or overacting, they're going to think like, hey, this person like says they're a 10 out of 10, they're sitting there calm, they don't have very many words. But I feel as a role of the clinician too, your job is when somebody comes in there and they schedule some of these new patient meetings for 60 minutes, it's not for you to be out there in 10 or 15, I tell them. I will make sure I'm going to get everything out of you. We will talk. I will ask you what you can do, you can't do, what you want to do. And I think as clinicians, we have to push for that. That's part of our job. Part of being a doctor, I don't look at it as just, the medications and this, but it's also the healing touch of just talk. There's sometimes I have talked to patients and they felt better because somebody just heard them. Just the fact that somebody listened to them for the first time, they felt better. And I know I'm not saying like just me, these are things that were taught to me. And so part of that is you go in with a bias, you go in with a certain mindset on a patient, you can't do that. And there's a lot of healing that takes place when somebody for the first time in their life, they'll tell, doctor, this is the first time somebody listened to me. It's the first time somebody just sat for 10, 15 minutes straight. I always say, tell me about it. And I just sit back, not me talking, not me interrupting, just absorbing everything they are. Even if they just got to release it on me, it's like, that's okay. So we can talk and have that dialogue. And I think it's just working on some of the things that can hinder people to get to that point. I think it's something I always try to advocate and educate, at least, with me and people who I'm going to be working with going, in the field. So.
That's amazing.
Yeah. And to piggyback on that, we know that different patient populations respond to treatments differently. So, part of the barriers are getting patients the appropriate treatment. And then part of the barrier, once they get the appropriate treatment, is understanding how we would expect them to respond and then not labeling them when they don't respond in the way our brain wants them to, right? And so when we talk about acute pain, we want to put numbers on everything because it's an easy way for us to objectify a subjective thing by putting a number on it. And that's why our pain scores all sorts come from. But chronic pain is very different, and you can't put a number on that pain. You can put a number on it, but what we've seen, and particularly in African-American patients, is that when they're treated appropriately, they still will report high pain scores, but their quality of life, their depression scores, and their function improve, which is what we really should be focusing on. Not to discount that pain score, but if that pain score is the only thing you're focusing on, what you're then telling that patient is repeatedly, oh, you're failing this medication, you're failing this medication. And you're putting them in this hole where they have less options and they feel like they have less options. And so there are validated scales we use in clinics to get at these things. And one of them is called the PEG scale. And so it's pain, enjoyment, and general activity. And so it's really getting at, okay, what's your pain in the last week? But then how much has pain interfered with your enjoyment of things? And how much has pain interfered with your general activity? So we're getting pain, mood, and function all in one. And what we want to see ideally is all of those numbers kind of trickle down, the lower the better. But what we see a lot of times is one of them trickles down and then followed by another one and then followed by another one. So focusing only on the pain number actually is a disservice to patients. So as been previously said, the more you talk about function and quality of life and limitations on your ability to live as a human, that's where we need to be focusing our care, and those need to be our goals of care, not necessarily a pain score, because pain scores can be very misleading.
And I'm really glad that you brought up the differences in responses to medications in particular, because I don't think that enough people realize that, one, there's a large disparity in participation in research, right? So most of the medications that we have been tested on a majority white population and younger population. And then many of the binders sometimes that are used in medications contain lactose, and we have a very large, minoritized population that is lactose intolerant, which can then affect the way in which these pain medications are tolerated by the body. And so I think at just a very basic level, sometimes that gets lost, that, medications, of course, at some level, I think people get it's not going to work the same for everybody, but I don't think that people really realize that, like, no, at a physiological level, there's some reasons as to why it may not, have the same responses, across different folks.
Yeah, just to kind of add to the medication discussion, since I've worked mostly with older adults who are on a lot of medications, we hear a lot that they do not want to take more medication for pain, that they're much more interested in alternative ways of managing pain for all kinds of reasons. But, especially they, just don't want one more medication that can, make them feel funny or out of it. And so we do, work a lot with teaching kind of non-medication ways to either, kind of as alternatives to medication or to possibly take less medication, but still, kind of use the other techniques when they can. And then just also wanted to emphasize the point about not focusing on pain and the pain number and the pain intensity, and in the pain self-management programs that Dr. Robinson Lane and I have done with older adults. We really emphasize that message about, it's all about increasing function and quality of life. And part of the reason is that, pain, it's such a multi-dimensional sort of experience in the brain. It's attention, it's emotion, it's sensation. And the more you actually focus on pain and wondering if you're reducing your pain, you're kind of paradoxically, at risk of increasing your pain for that reason. So we find that if people are focused more on function, on doing the things they want to do, on good quality of life, kind of almost as a side effect, their pain does go down a little bit. But if the goal is to get that pain number down, it's just not as effective. So just wanted to kind of add that.
And also, I think related to the non-pharmacological, so the herbal supplements, the home remedies, and all of those sorts of things, I think when you're dealing with older adults and minoritized populations, it's really critically important for providers and clinicians to, one, confront their own biases about that, become familiar with the sorts of treatments that individuals do, and to raise these sorts of questions when you're talking about pain treatment, because often the conversation shifts to pharmacological treatment and we don't ask about all of the stuff that people are doing to self-manage pain. And sometimes there's some fear and stigma there. So for example, particularly here in the state of Michigan, now that, marijuana is legal both for treating medical conditions as well as recreationally, a lot of individuals, particularly older adults, are using substances like marijuana, as well as a lot of CBD products to manage pain. But if they have a concern because there's a long history of pain clinics rejecting individuals for using marijuana, they may not disclose that information, or if it seems like somebody might make fun of their remedy that's working, or they might not even think of something that they're doing as a remedy. So for example, a lot of older adults will take a hot bath with Epsom salt for pain, and they don't think about that as a treatment because that's just what you do. But that's what happens when you add culture into the conversation. Is the things that we do that's normal to us is normal to us and the folks that are around us and the way that we're raised, but it's not necessarily going to be normal to the person that you're interacting with.
Interesting. I appreciate those discussions about the cultural responsive care practices and some of those things that are being done. And I wonder how that enters the mainstream. So, I mean, you talked about the biases that can come along with that, but when you get to a point where, okay, medication is not going to take this down to zero, you're going to have to deal with some pain. how much do clinicians actually helps patients to consider alternative therapies and therapies that may not, be out of a medicine bottle?
Yeah, I mean, I think it's something that is increasing. I know just being able to have the opportunity to do my fellowship here, those are different things that we offer. So there's a lot of things where we're being trained in, where it's not just, we have a whole non-pharmacological department. So we have things from acupuncture, we have massage therapy, healing touch, we have, seeing the pain psychologist. There's a lot of different aspects. So I think those things are always things we address, including like the medications, like which so eloquently stated. Those are things that are always need to be discussed with every patient. So when we go through the different things, I've even list those. Have you been to this? Have you done that? And listen to these things every time. Because sometimes they're like, well, acupuncture, is that even if they don't know, they do know, they're like, is that something? Yes. Is healing touch something? Yes. Is the pain psychologist something to see to help learn how to cope with chronic pain? Yes. And these things that every patient I see, I want to educate, because some patients I come in, I'm an interventionalist. So I like to do procedures. So I actually am not the one, even with all the pharmacological education. I'm like, how can we not have you on medications? If I need to, I use them because they can be effective in some cases. But again, I want to try to figure out, I think a lot of times is when you have a patient come in, and like you said, understanding different cultures. Once you've been around a lot of different, I know kind of what people are kind of looking for. I know when a patient comes in, because I know how my mama was, and I had to get her to get the pain medicine, and she wanted the alternative stuff. So I know, like, being able to open up that conversation in the beginning opens them up, and it actually makes them more open to maybe having a pharmacologic agent if they do want it. Like, you know what? Like, he's talking to me about, different remedies, and I'm like, yeah, that's something that could help, or it doesn't impede with the medication. And I make sure if they're doing something, I look at all their whole list of medications, make sure there's no interaction with the blood pressure medication or the blood thinner. And I'm like, yeah, no, that doesn't affect it. Sure. And so building that bond allows you to be able to bridge other gaps for different ways of medication, whether it's non-pharmacological, whether it's pharmacological medications, and whether it's like interventional things that we do. I think building that trust between a patient and a clinician is important. And so, like I said, those things that build that trust, there's have to be understanding between the patient and the clinician. And so if you're not willing to kind of build that understanding, build that trust, you can't properly care for a patient. It's just not, it's not proper patient care. So that's something I always push and preach to the top of my lungs, because, I went through it. I went through it myself. I went through it with, being where I'm from, growing up in an area where people were, very, very bad medical care where I was from. So I've seen it growing up. I've seen how it was, seen the treatment of it, mother going through cancer. So I've seen this firsthand. And I see the pit stops. I see the things that happen during these like interactions, during these, where you're sitting on a fly on the wall and they don't know I'm a doctor. I was just like sitting there and I'm just like, they don't know. I'm just listening just to like, peep out how they're acting. I'm just like, man, this is crazy. But I think that's something as clinicians that we have to continue to improve and continue to educate. And, we can talk about that for another 30 minutes, how we can go along that path to do it. But I'll let somebody else kind of jump in here.
To piggyback what Dr. Harris said, I think what we all need to understand and what the community needs to understand, that there's no magic bullet. Pain experience is different for everybody. And outside of like maybe the headache and Motrin helps it, like that's not the usual pain experience for most people that are dealing with these things. And rather than offering a single option and saying like drug, no drug, we really need to make sure that we're offering and considering a menu of options and saying, here are things that may work for you. I believe these may work a little bit better. These are also safe things that you could try. What do you want to try? What are you interested in? Part of this is certainly patient buy-in, but part of this approach needs to be starting out with every possible option that we have and saying, these are things that we could try, right? You have a lot of things in front of you. Some are drugs, some are not drugs, some are things you're going to do at home, and making sure that patients have those options. And I think that communication, and even with marijuana, an open dialogue. I don't care what you use to treat your pain as long as you're safe, because at the end of the day, my job is to help you not have pain. And if that means you're smoking marijuana to not have pain and you're doing it safely, that's awesome. That means you don't have pain and your quality of life and your view is better. And that's what we should be shooting for. And I think that clear communication and dialogue, so we are all on the same page to make sure everything's safe. And here's your menu of options. And it's a decision between the group of people helping to manage that pain, not a one-way street.
And I think that this is a good point to bring up how important that is, because I think Mary should talk a bit about the research that's happening there, because we've seen success in giving people options that are, non-pharmacological to supplement what they may be doing medication-wise, and we've seen clinically significant decreases in pain that's happening at the community level and outside of a clinical practice area.
Yeah, no, so we've done a couple of pilot studies, and now Dr. Robinson-Lane and I are involved in a large trial that's funded by the National Institute on Aging, a study of it's a randomized clinical trial of a chronic pain self-management program called STEPS, and it's delivered by community health workers largely, but participants also receive educational material. They view educational videos, teaching skills to live better with pain, cope better with pain. So it's things like gradually increasing physical activity, which is actually a really powerful analgesic. It's relaxation, stress management, trying to re-engage in pleasant activities that sometimes, fall off the radar when you're just trying to live with your disabling pain. And so I think one thing that kind of sets this program apart is that the community health workers, so first of all, they do, I think, a lot of what Dr. Harris was mentioning, which is they're just listening. So they have the time, and they have kind of a close connection with participants. There's a really strong rapport there, and they just listen to the pain stories of the participants that they're talking to. And I think that in itself can be really therapeutic. As I said, the community health workers are from the communities. They have similar lived experiences, and so they're able to, kind of listen to not just about the pain, but about some of the remedies, some of the culturally specific remedies, and kind of talk about those. But then also community health workers can address some of the social determinants of health. So we haven't talked about this a lot yet, but we talk about all these things that influence pain and someone's pain experience, but those are also shaped by the environments in which people live, work, and play and pray, the social context. And so community health workers are like social workers in that they are able to connect people to resources that they need to address some of the issues that they may be having, whether they're housing or not able to get the medical device they need, or get their roof fixed, or just kind of all the things that actually we don't think of those things as being causes of pain, but they are causes of stress. They can be causes of poor health, and all of that can lead to pain. So with this intervention, we are trying to address, I guess, in a really holistic way, including some of these bigger factors, what the things are that cause pain, that cause pain to persist. And by intervening in that way, people can are able to live better lives with pain, have less pain interference. And as Sheria said, we in our pilot studies, we did see some pretty significant improvements in how people rated their daily functioning with pain, their pain interference, and even pain intensity. So we're hopeful that this kind of more holistic treatment for pain and giving people a lot of options. That was another part of the program, is, letting them know about this kind of whole menu that Dr. Smith was talking about, of different, things that you can try. If it doesn't work, that's okay. Try something else, try a combination. So we're hopeful that we can show really good results, that this could more often be an adjunct to care, because I think, in the typical healthcare system, there's just not kind of the time and place to give this sort of more comprehensive, intense support for chronic pain management, but it can make a big difference.
So I want to thank you all for sharing those important points about these alternative measures, and congratulations on your grant funding for that study. Dr. Janevic. I want to get back to the disparities that individuals, and we'll focus on African Americans, experience in getting the treatment that they need. There are documented studies that show these differences. I think some of that came out in a conversation that we had here in the College of Pharmacy featuring Dr. Michael Smith last year. And one of the studies focused on lay persons as well as clinically trained individuals and their perceptions of differences in pain, the perception of pain based on race. Dr. Smith, can you talk a bit about that study just to kind of lay some historical context for these disparities? And I'd like to know where we are today with regard to that.
Certainly. The one study was of medical students and laypersons, and what came out of that study was that there was a belief that African American patients had a greater pain threshold due to skin thickness, which was one of the primary ones, which is actually the exact opposite of what is actually true. And what we really know is that African American patients actually report a greater sensitivity to pain. This has come out in both clinical studies and preclinical studies where like they'll put electric stimulation on patients and see what level patients will report pain at. And so I think there's this belief of part of it was skin color, to be frank, that led to the belief that those patients have higher pain thresholds, meaning that they're not likely to experience pain, when the exact opposite of that is true. And that study is a bit old, I believe, at this point. And at least I hope our training has advanced well beyond that in our understanding, but I'm sure that belief still persists.
And how do we confront these biases? Part of the theme for our events has been confronting these inequities and trying to write prescriptions for change, if you will. How do we confront these? We still deal with these disparities, these inequities on a regular basis. How is it being addressed in the curriculum? Dr. Harris, I don't know if you had any opportunities to encounter any misperceptions in your education, but I want to know how we get beyond that and kind of move into a different place where we can all be treated equally for this.
Yeah, so this definitely still does exist. So unfortunately, no surprise there. I think a lot of it is education. So one of the things when I was at one of my previous institutions, being the head of diversity and inclusion and different things that we worked on there, one of the big things we looked at was implicit bias. And people, we had everybody run through these different tests, and they'll show different patients. Which patient do you find to be more difficult? Which patient would you think would be non-compliant? And everybody took it. And then after we took it, I had a lot of people mad at me because they were saying, "Hey, I'm not like that, Mark. What was it this test?" I'm like, look, again, a lot of people look at this as, hey, I never thought this, or I don't hate. Look, I'm not here saying you're somebody, running out there with putting crosses in yards, to excuse my wording, but the things that you might not think or not even realize that you're doing are affecting patients. You're being biased towards a patient. You're having a perceived thought or an idea about a patient. And these are things that need to be educated. These are things like every person who comes in to training should have this done. When you come in first year of medical school, this implicit bias test needs to be done for every single person who's nurses, doctors, PAs, MPs. If you're in this field, it needs to be done, because when we did it, people couldn't believe it. Theirs was like, they were like, literally, I remember one girl was like, "I go to Africa every year and volunteer." She had one of the worst scores, but it's just what it was, in those things. And people don't realize these different things that they might do that overall are going to affect patient care. So I think implicit bias studies, I think training, these things need to be done from the ground zero. As soon as you enter in, go ahead.
Once you do that, what's the next step? So
Then
if
I
you
think
find
so
out,
then-
oh my gosh,
So I think in the next step, and I think the next step, these are discussions that should also be part of the curriculum that I've had. One of the big things is why we talk about just having diversity in the people in our field. That's another big thing, because what happens is these are conversations where if you have a place where you don't have any diversity, people who have been in, who are from these different backgrounds can't share the stories, can't share how they're going to look at a situation or how they perceive. So having a diversification, people kind of look at it as like, oh, well, you just want to put somebody in. No, it's not just about having diverse people who are providing the care, but that diversification of the people who are providing care actually improves patient care. And so that improvement in patient care is very important. So again, you have this implicit bias. Once you do it, then we start doing classes where we talk about different cultures, where we explain to it. So we're, one of the places I trained, we had a large Somalian population. So we had classes explaining the different culture, the different beliefs, things like this. Same thing what we did for African American, we did definitely for a Hispanic, and we went through these different things. So we had these classes focusing on different minority groups and teaching them, hey, it might not be that this person is coming in not wanting to talk to you, but there's a history of African Americans having a distrust with doctors. If you don't know that history, then it's like we can't have a conversation. So educating on that, the Tuskegee Airmen with the syphilis. I talk to doctors and they act like they never heard of it. Those things are rooted into the community. And so you need people who represent that in the field who can able to discuss that, but you need to have these trainings with the doctors that you need to go through. That's part of your normal medical training, because we do a lot of extra stuff that's also not necessary. This will be something that will be very important, and it needs to go through all 4 years, whether you're nursing school for your 2 years or PA school for 4 years. This needs to be done, and then this needs to be repeated. This is not just something that stops at medical school. We have all these things that University of Michigan makes me do, and all these different things I got to update on with these things. This is not one of them. Needs to be one of them, not just one. I need 6, 7, 8, 9, 10 of these with different ones where we're really explaining this. So that's what I would do. That's where I would be. So getting a little excited, but I'll let somebody else jump in.
Excellent. Anybody else have suggestions regarding this?
To add on to that, I think what needs to then happen is to go back to what Dr. Harris said initially, is connect us back to the fact that pain and nociception are not the same thing. And that is really underlying it. Pain is an experience. Pain is not just physiology. And I think that on top of everything that Dr. Harris mentions starts to break those issues that we're having. Pain is not just how your nerves connect and send the signal, because pain is well more than just that little process. That's one very, very small portion of it. And I think starting with what Dr. Harris said, and then really connecting it back, and not just to pain, to everything and how diseases really work and all that they encompass. We don't do that connection often enough, if at all, to be honest with you.
Well, and I think from the patient, family, clinician, particularly the nurses that are out there, I think that all of us can attest to sometimes how difficult it is for advocating for folks, and then also not being heard sometimes. So I think that it's important to learn the ways to do that, because everybody has bias, right? So I think folks have to, one, acknowledge the bias that they have, for one thing, certainly as Dr. Harris spoke to, but also we have to become more accustomed to being able to effectively advocate. And one of the ways that I think are already mentioned that you can do that is by being really clear and documenting the functional declines and the challenges that individuals are experiencing, because then what that does is it forces the provider to have to respond in some sort of way. So it makes a large difference if within the documentation you just saying you notified whoever versus you list out all of the problems and who you notified, because and then you let them know, so you want me to say that you're not going to do anything, and then they'll say, well, hold on one second, what do you mean? And let's talk about that again. And I found that very highly effective in being able to get appropriate treatment. And in many instances, the more familiar you become as clinicians and family members about treatments that have been effective, or what your concerns are, and being able to voice that, then it leads to more collaborative conversations that can result in pain treatment that works for that person, that family, and that community.
Okay, thank you all. I want to get to some questions that are in the chat. So this question takes us to the opioid crisis. And the question is, how do you balance the opioid epidemic and wanting to prevent fueling addictions while also meeting patients' needs and improving their quality of life? Should we be focusing on meditation, movement therapy? So that goes to some of the other treatments that we had talked about. But this was a question that I also had for the panelists. How does the opioid epidemic factor into this? And yeah, so if you could chat about that a bit, that'd be great.
I think I can jump in and kind of hit on that real quick, and then others can join in. So we're in this pendulum, I'm going to call it, where before pain was considered the fifth vital sign, and we were focusing on that, and we were overusing drugs when we didn't need to use drugs. Those at the time happened to be opioids, and there was many reasons and pushes to focus on that from a quality standpoint, from a reimbursement standpoint, from a patient satisfaction standpoint. And then, you know, the pendulum swung the other way, and the hammer came down that opioids are horrible and no one should get them, and everybody's going to die if they take an opioid. And the CDC guidelines got wildly misinterpreted. Insurance companies and pharmacies were limiting them severely. And, if you don't know, the CDC is working on an update to those. And I think, on my view of it, is that pendulum from the opioid is starting to come back towards the middle. There are certainly patients who benefit from a functional standpoint of using opioids. When you use them, it's a matter of using them safely. So keep the dose low. We have to be mindful of patients developing tolerance, mindful of other drugs that increase their opioid-related risk, like benzodiazepines and gabapentinoids. Give them naloxone prescriptions and educate them on safe medication use, while also doing all those other things, right? So meditation, movement therapy, everything else. Like we talked about earlier, one pill or one drug or even one non-drug activity is not necessarily going to be your magic bullet. It's about continuing to use that menu, keep that menu open, and evaluate that menu every time you see the patient.
The opioid crisis, I think, was quite devastating to older adults, and particularly minoritized older adults in particular, because there's certainly a lot of bias around those groups, and the amount of medication adherence, lack of adherence that happens is not because of overuse or misuse and taking too many pills. If you will, it's often with individuals being hesitant and not taking medication because of concerns around addiction and tolerance. And so one of the things that we know, like for example, is that it's more difficult to get certain medications, particularly opioids, based on zip code. So when you live in a lower income zip code area, they don't stock medications in the same sorts of ways. If you're trying to get a prescription filled, you can often be forced to go to multiple pharmacies in order to get the medication that you need. And the pharmacies just simply, honestly, aren't helpful. Even personally, we've experienced that, having a family member had surgery, and then we didn't think to get it at the hospital before we left, tried to get it at the local pharmacist. See, after going to the third pharmacy, I tweeted about it because I was so irritated, and then got a personal phone call from CVS to help, and it was in a zip code that was in a higher income area where we were able to obtain the medications. But at each location, nobody would tell you because of some of the, I guess, regulations around sharing that sort of information. So I think that one of the things that was most concerning to me at the start of the, I think, epidemic was this concern that populations that already had challenges getting the medications that they needed and being discriminated against in that process, we're going to experience even more disparities. And that's, I believe, what happened. And I don't know that, I certainly haven't looked to see like what the sorts of ways were that people were self-managing, but I know that in sort of, I guess, more anecdotal conversations and some of the focus groups that we've had with older adults that have experienced pain, I can see that what I have observed is more people are using things like marijuana to, manage pain. Now, is that a good thing or a bad thing? I don't know, but it shouldn't be that people are forced to sort of have to figure things out on their own due to a lack of access and bias.
And I definitely agree. I think with everything with that, and I think with that kind of swing. So obviously, from a clinician standpoint, and obviously with the changes that are going to be happening going forward, it puts pressure. And so what happens is always in these things, when you have these things where it's like, okay, here's the pressure, we can't prescribe certain medications. That pressure to not prescribe it is always going to affect kind of those underrepresented groups. It's just it's unfortunately, it's always the brunt of kind of where that's going to fall. So, a lot of times you'll see sometimes where literally a patient will come in, you'll see somebody look up the zip code and be like, oh, watch out for this patient. We haven't even said a word. We haven't even seen that patient. We don't know what they look like. Just basically looking off what the address said, where the person lives already. I heard this where it's like, oh, gotta watch out for this person. I know you're not from, I'm new to Michigan. I'm from California. So they're like, hey, if you see somebody from this neighborhood or this zip code, watch out. And it's like, we haven't even seen that patient. We don't know their story. We don't know like what happened. It's not even like we're looking at it where you're like pulling up the maps and you're looking like this is literally just off a zip code off bat. It's like, okay, watch out. It's like, obviously for me, when you hear something like that, I'm like, well, here we go again with, assuming and kind of like literally jump into conclusions with it. But I think overall in regard with the opioid epidemic, again, I think in the way just, with the training and when you see these patients, it's like you said, providing kind of like the holistic care, that holistic of all the options. And again, functionality is key. You can prescribe, the same thing with our clinicians, you can prescribe an opioid. It's how you document. The one thing that why a lot of clinicians get scared is you do get in trouble. There is a fear of getting in trouble for providing them, right? But one of the keys to that being okay when they go and review you, or if they want to say, okay, I'm going to review all your paperwork, is the documentation. Functionality, what's improving. And again, it goes back to what we talked about is those are the things that need to be assessed. They're looking for that if you're going to be prescribing that medication. And so if a patient is on, 30 OMEs of opioid, then, and they're having great functionality, that's documented. That's something that can provide them, that can help them in conjunction of other things in their care. It's a piece of the puzzle. It's not the whole puzzle. And I think being able to talk to patients and guiding them and letting them know, hey, and there's sometimes where that's not, might not be the first option, but letting them know like, hey, here's why I say it's the first line. Here's what I think, this is what it shows. It might not be the direction that we end up staying at, but this is why we're going to give it a try. Patients, I think it's something they respond to. And again, it's just those communication and being open that that person is not coming in just for that or seeking that or your fear of prescribing it, but that you actually have that opportunity to kind of hear the patient out and kind of, try to tailor something that's going to help that patient kind of manage their pain. So
I think the whole issue of drug seeking is somewhat connected to the opioid epidemic, at least currently. And we've had questions that were placed in the Q&A, and also we received questions about this in the registrations about how someone can advocate for themselves. Being a woman, being Black, being from a lower socioeconomic group, when they will be presumed to be drug seeking. And I think, Dr. Smith, I heard you reference in the previous session that I referred to earlier, a study where there were patients that were being profiled based on their behaviors. And the majority of the patients that exhibited drug-seeking behaviors were white and not Black. And can you talk about that a bit? And then can we talk about how patients can advocate for themselves if they know that this is what they need without being thought as a drug-seeking patient, to be a drug-seeking patient?
Correct. And there's two different studies. There's one that looked at those behaviors that showed that white patients were more likely significantly to exhibit drug-seeking behaviors, although that's a pretty poor label. The other one that's really interesting is there was a mixed method study that looked at what would cause a physician to label a patient as drug seeking. And the one thing, and it wasn't race, so they looked at race and gender and other factors. The one that it actually was, which is mind boggling to me, is mentioning a drug by name was more likely to have you labeled as being a drug seeker. To me, I read that more as somebody who has medical experience, like they've been in the hospital, they know what works for them. Okay, you're helping me understand your care. But the fact that came out in a study is, I think, pretty appalling. And I think the way to go around this until we can fix those issues is for advocating is what has been discussed before, talking about your function, whether or not you necessarily know something works for you. I think after you've had that discussion and the person treating you understands what your limitations are and what's going on, then starting to bring in medications that have not worked, I think is important. For me, if somebody's not telling me, I'm asking them and I want to know. And if they don't remember, I'll go chart digging. But that's not going to be everybody's ability or understanding to do that. So I think part of this is framing it and what's most important up front. What's most important is the patient's experience. What is happening? How do we fix this right now to move them past whatever it is? And then how do we treat them long term?
And how do we integrate this into the curriculum? So across all of our disciplines that are represented by our health sciences units on campus, how can we begin to teach our trainees, our current students about these issues? So we've talked about the implicit bias and, taking those tests, but having them to come out of our programs with a different way of thinking so that these assumptions aren't being made and we aren't having this discussion again 10 years, 20 years later. Are there any things that you would recommend to those that are in this meeting, listening to this session today, on how we can do something, what we can do in our curricula to make change?
Yeah, again, I mean, it's so in medical school, like I said, they have, medical school can be big and be 200, 300 students in a medical school. We have small groups who have different discussion about different things in medicine. A lot of it's just the book stuff and different treatments and things. These are things that need to be implemented as part of our discussion. Most medical schools, if not all, have small groups. They do small group discussions. There's different articles that you bring. There's different subjects in medicine that we bring up for discussions, and we discuss articles. These are things that need to be implemented where this is a discussion. These are lectures. This is part of the training. And I think, there's medical schools that are starting to work towards that and implement that more. And it just has to just be the base of part of the education. Just if you have to learn the physiology, the pharmacology, the anatomy, this should be another pillar of what you have to study in your training. And it just needs to be part of just the medical training. Like, this is what you need to study. This is going to be on your medical school exam. These are things that need to be ingrained where people are recognized, because the lack of knowledge or the recognition of some of these issues, they have no idea. So, if somebody has no idea that they're doing a certain thing or they have these biases or understand these differences or that this is an issue, and we can, poll them and ask. We did a poll, before when I was doing research on this, and we polled like, is this and most people didn't know it was an issue. So you're having the people who are the future doctors of this country not even knowing this is something that's even significant. So again, it will be something that needs to be integrated at the ground level and part of the training for you to finish, for these things to really kind of take hold. It can't just be a one-off little discussion you go through in an hour at the end of like your rotation where everybody's ready to go home. It's like, no, this is something we're going to sit in and have small group discussion for 3 hours, and we're going to sit down and really talk and really educate and really look at different perspectives in medicine outside of just just the kind of the science behind it. So
are any of the societies addressing this? So you've got societies associated with all of your fields. Has this risen to the top as an issue there? Because I'm wondering, if we know that this is an issue, or some know that it's an issue, how do we begin to get it into the curriculum? How do people begin to take notice of this and really take action on making sure that we are being trained in a way that results in actions that are fair and equitable with regard to healthcare? And I guess this begins to span across the board, not just in pain management, but in all areas within healthcare.
I think that, of course, over the past year, there's been increased attention and focus to anti-racism work. And so I think that there's a lot more attention, there's more funding to begin to approach these issues. And I think that the societies are beginning to consider. I know the American Nurses Association is in the process of reevaluating and rethinking some things, but is anything actually out at this point? I can say for us, no. And I guess I'm not very optimistic from that standpoint. I mean, things look good right now, but it only took, one change in administration to even remove our ability to talk openly about racism and discrimination and these sorts of things. And so I think that this has to happen at the organization level. Organizations have to take on the ethical charge of creating inclusive environments, because right now we're talking about anti-racism and the provision of healthcare services, but it also ties to discrimination against persons with disabilities, persons with ageism, older folks. The older you get, for whatever reason, I guess you don't have the same pain because they don't want to treat you the same. The older you get, I've seen people with long bone fractures come back with Tylenol prescribed. So, and then with young kids, that, they often aren't treated the same in regards to their pain management. And I think of all of these populations, the people that are treated the absolute worst are persons with histories of addiction. So the ones who have built up some tolerance to some sorts of treatments, that probably don't have great coping skills, that may have built some things that need more support, are often getting the worst care. And so I think that, it has to be a collective responsibility, that we can't wait on these organizations to lead these charges. It has to come from us as clinicians, as family members. And yes, it's burdensome. I saw somebody in the chat says, like that shouldn't be right, that we have to advocate for ourselves. But I mean, honestly, that's the only way that we've gotten things done, is by advocating for ourselves. These biases in pain management have been around since the antebellum period. I mean, this stuff came from Thomas Hilton, who was, had a plantation. And so he was the one who started a lot of this, these misbeliefs and the research that he was doing based upon his beliefs and biases about Black skin and pain tolerance and blood coagulation. And we have studies as recently as, I believe, 2019 that evidence that it still is apparent in medical school. So I say all that to say that I think that it's important to encourage our professional organizations to do more. But I think all of us have a responsibility of confronting, thinking more about bias and how do we limit bias in our assessment and treatment, as well as how do we create more inclusive practices.
And we need the time to do it. So I think if we were to all look at our curriculum and say, how much time proportionally do we spend teaching pain management versus other things, it's probably a lot smaller than it should be. I don't think it's right sized. More people have pain. I know Paul Hilliard's on the line and he's said this before. More people have pain than cancer, diabetes, and heart disease. But I guarantee if we look at all of our curriculums, you're spending more time teaching and learning about cancer, heart disease, and diabetes than you are pain. And so how do we have such a large societal problem and patient problem, yet we have so little time to teach it? That's my personal bias because I love pain, right? But we don't spend enough time teaching about it. And I think that that's step one. And, you know, as Dr. Harris suggested, getting into small groups and discussing it, that takes time. So all of our educational institutions need to give us the time in the curriculum in order to be able to actually discuss these things at the length that they're needed. 100 million Americans is a lot of people, and that's just the United States.
Just wanted to bring up one more thing in terms of sources of bias that it's going to be important to address, and that is in big data and machine learning and AI. I think this, you know, we're kind of on the cusp of, I think, you know, a lot of advances being made there that probably eventually will kind of trickle down into patient care. And this is, you know, it's not my area of expertise, but I know that I've, you know, read things. If the systems, the algorithms are not trained on diverse data, they can be biased in, you know, all kinds of ways. And so I think it's really important to train health informatics students, people who are learning how to do those things, to do that in a way that's inclusive and is going to represent, you know, the entire spectrum of patients, so it will be valid. So that was, you know, from the kind of public health standpoint, I think that's one thing that's really important to think about in the future.
Okay, I want to grab a quick question from the Q&A, kind of related to our previous discussion about the label drug seeking. The question is, how do we stop labeling patients who are in pain? For example, DE&I has a list of unacceptable labels and words. Can we consider eliminating that word drug seeker for people that are in pain? Just wanted to get your thoughts about that.
I mean, yeah, that and not compliant. Because I mean, you know, my issue with even non-compliant is, did you have a conversation to see what they agreed to do before you decided that they were non-compliant, you know, with something? So, and I think the issues, particularly around drug seeking, is that oftentimes it's evidence of undertreatment of pain and a misunderstanding of things like tolerance, you know, and unfortunately, there's wide variance in pain education, you know, as has been discussed. And at the end of the day, you can do all the educating you want. If somebody's beliefs aren't changed, it's not necessarily going to change their approach, because you can go to a full 6-hour in-service on pain management and somebody tells you they have pain and you still look at them sideways because they aren't responding to the pain in the way that you would. And I think that's one of the challenges that we spoke about in the very beginning about pain, is because it's something all of us have experienced, and because it is an emotional and historically tied, meaning it's tied to your own personal story. So whenever any of us think about pain, we think about it in the context of our own pain experiences. So what does that mean if, for example, you are a mother and have experienced childbirth and you currently have chronic pain and you're at work as a nurse and you're working on the floor and somebody's telling you they're having extreme pain and you're comparing your pain experience to theirs, and then how you feel as though it should be treated, or any clinician for that matter. So
Thank you, Sheria. So I have a question that I want to get to from the Q&A, another question. The question is, has anyone read Pain, A Political History by Kenneth Waylu? If so, how do you think our political history at the macro scale has influenced pain management on an individual patient level?
I have not read that particular book, but I mean, from a historical perspective, there's a very large history of experimentation done on disenfranchised population without pain treatment, in which individuals who have done that experimentation has been lifted up for the outcomes of that research, and which we have justified some of the mistreatment of populations. And so I think our book discussion that we will be discussing for our next health sciences event is Harriet Washington's Medical Apartheid. And in that book, I believe in the first, either the prologue or the first chapter, she talks about how rampant some of this experimentation was, in which slaves in particular were compared to cats, and saying it was, easier to do experimentation on a Black person than it was on an animal, due to the availability. So there's a very long history that I think a lot of people are not familiar with, that is, of course, deeply political, which is why we continue to see a lot of the challenges that we do in implementing change, because it's not just medical, it's not just social, it's not just cultural or environmental, it also is certainly political and socioeconomical.
Absolutely. And Sheria, thanks for that plug to the book dialogue. We do encourage you all to consider attending our book dialogue next month, about where we will discuss some of these issues. But anybody else have a response to that question?
Yeah, I can add on it. It goes the other way as well, in terms of, like, take marijuana as an example. I know that's popped up in the chat a couple of times. That was never tested before it was put on the Schedule 1 list. It was, done so for political reasons and said this is horrible, and yet we're finding more and more out later. So there's these like two extremes of incredibly inappropriate testing methods and incredibly inappropriate not testing methods, where we're not even giving things a chance. And we certainly have not found that middle ground where we're doing things appropriately across all fronts.
Yeah, and I haven't read the book, although it is on my list. But when I think of history and pain, I think about the unequal burden of pain in this country, and how the prevalence of pain is really patterned by racialized group and socioeconomic status, but in particular how political decisions, and especially those supporting systemic racism, have kind of created conditions that makes pain so much more prevalent and severe and disabling in African Americans and other minoritized groups. And so I think, and historical trauma, I think, can perpetuate pain in those groups. And so I do think there's a very close link between health in general and pain in particular, and the history of our country, and how we came to be where we are now. And I think that that's why, in order to make a more equitable society in terms of pain, those bigger factors do have to be addressed. We have to change health policy, social policy, to make a more equitable society. And I think all of these things are important that we're talking about in terms of interactions with the healthcare system. But at the end of the day, I think, there are bigger societal solutions to some of these things as well.
Yeah, and I think, just to piggyback on that, I think a lot of it, like you said, a lot of it would be political. I know, growing up, living in different neighborhoods around the country, including Compton, California, where that was kind of the capital for a lot of things that was happening with the crack epidemic, opioid epidemic following that happened there. And, one of the things I remember this being an issue, and living there as a kid and growing up. And it wasn't, this is something that went on for a long time. By the time it reached even being something that was mainstream is when it reached certain neighborhoods, because it was definitely in my neighborhood that whole time through. But when it reached certain neighborhoods, there's been issues. There were even different research studies where they'll take, people from the neighborhood who would, have these withdrawals and things like that. And they will say, well, how about we don't give them anything and see how long they will take them to withdraw? What would happen if they go through 24 and you would actually get paid because they knew these patients would, because, they had this addiction to they had it and they were using like heroin, but they'll bring them in and actually put them through really deep withdrawals to kind of see how they go. This was happening. I seen this because I know it happened with my uncle. So I seen this where they were taking them, and he was telling us about this study that he was getting paid $20 for, where they were basically letting him withdraw to the point where he was about to die, but he would go back so he can get the $20 when he was struggling through that. So again, there's a big political charge with it, and there's definitely been a discrepancy, and that was going on, and that's my lifetime. I'm not even that old. I'm in my 30s, so this is something that's was going on as I was growing up, and I seen firsthand. So again, just to piggyback on that and add to that.
Unbelievable. I mean, those are some of the topics that are addressed in Harriet Washington's book, and here's another instance. Thanks for sharing that, Dr. Harris. So I want to pull another question from the Q&A, and this is about D&I training that we've talked about a bit. And so the question is, are DE&I trainings actually effective? How would you counter pushback to constant DEI training? That's diversity, equity, and inclusion. I worked in the Chronic Disease Prevention and Health Promotion Center at the CDC, and many colleagues expressed that they were exhausted and resented discussing and participating in DEI trainings. Any thoughts? I would imagine that same level of exhaustion might be experienced here in our own community. How do we communicate the value of these trainings?
I think one place I like to start is facts. You demonstrate what the outcomes are as to why we have to have these trainings and why the solution is at the provider level or at the level that the trainings are taking place. Because in the same token, I think that sometimes education is an easy intervention. So we're at times maybe quick to say, let's educate, when maybe that's not quite where the problem is. So I think that a little bit of both has to take place. We want to make sure that education is the right intervention and for the right group, but then also part of the education process should be to, and that's a part of adult education, is demonstrating needed relevance and then bringing in people's experiences with that as well.
Yeah, and to piggyback on Dr. Robertson Lane, she's 100% right. I mean, part of this is, and this is starting to be, is these patient surveys. And when these patient surveys come back, like you said, these are facts. This is information. You have a group saying this is an issue, and to sweep it on the rug. So again, those are things you got to bring to the forefront. You got to bring to discussion. Where you have demographics that don't feel like they're being properly cared for, or their quality of care is not, matching up to what should be expected. And so that's a driver in a lot of that's driver in reimbursement. But I feel like sometimes it gets kind of swept under the rug with, in certain groups overall. So that's something you push and you bring to the forefront. Also, too, a lot of the stuff that they give, it's very passive. So this needs to be active. We're having an active discussion. This isn't a passive thing. This is an active discussion. We're bringing things. We have people who are watching, who are bringing in questions. It needs to be active. Too much passive where it's just like, hey, you put somebody in front and you have them sit and just listen for an hour or two. Yeah, people get burned out sitting down. Everybody's been in lectures and studying. They get tired of being in that lecture talking. One of the reasons I like with the small groups is this active where there's only 10, 12 people in this room. Everybody's going to have a discussion where everybody's going to participate. Everybody's going to bring something to the discussion. So I think a little bit more active, a little bit less passive. And again, like Dr. Robertson Lane said, bring the facts, because it's there. It's factual, and bringing these things to the forefront. So you might be tired of it, but it's an issue. So, this is something we're going to have to correct and work on. So.
Great. So much has been shared here today. I think we definitely have a lot of work to do. And as we come to the end of our time, I just want to give everybody an opportunity to share any final words about like what the next step might be. How do we pull all this together and move forward? We've got about 6 minutes for that. Anybody want to jump in to quickly share?
I'll quickly share. We need to keep listening on the patient-to-patient level, listening to people that are telling us how they feel, and particularly those in pain. That experience is unique to everybody, and the first thing that we can and should always do is listen.
Yeah, absolutely. And just in terms of a policy change, I think if more non-pharmacological treatments were covered by insurance, more people would have access to those and be able to utilize them, because that really is optimal pain management. So I think that's a policy solution to advocate and fight for.
And along those same lines, I think getting more engaged with community partners and organizations who are able to offer a lot of these non-pharmacological interventions and are doing so in very accessible ways is important. I think one of the things that Mary and I have found through some of the focus groups is that one of the primary ways some people are currently accessing this is because some of these services are covered through like the VA. And places like local community centers are offering things like acupuncture and free swimming for people of, that either live in the neighborhood or of particular ages. So being more connected with what's available in the communities that you service is also important because it doesn't mean that everybody has to do the job. So we may be able, for example, at University of Michigan to bring in the funding, but we don't necessarily have to do the work. We may have to be able to partner with our communities and assist them in doing the work that they're great at.
And then I just will add one of the things I preach is patient-specific care with a holistic approach, diversification of the medical field as a whole, and education. And to me, those are kind of the big things I always preach is you got to educate yourself. You do have to diversify the field as a whole, because these are people who are going to be taking care of the patients. And in the end, they show studies where diversification of medical schools and hospitals and staff leads to better patient care and better patient outcomes. In addition to that, you have to be patient specific. Every time you get a patient, it's about how you're going to treat that individual. It's not a textbook. This isn't a test question. Every patient is different. There's no one patient that's the same. So you need to figure out, yes, there's common things that we use. We all know that, but every patient needs to be addressed, patient-centered care. And, those would be kind of my things I would probably, continue to preach going forward.
Thank you all so much for participating in this panel today, for all of the wisdom you shared, for all of the experience that you've shared with everyone here today. Thank you to all of our guests for joining us. I'd like to remind you that on our website, our MLK Health Sciences website, we will have the recording available. We had a few requests to share the chat, and we will do our best to try to make that available to you too, because we appreciate all the resources that some of you shared in the chat. And I also mentioned that we have a resource document that we created, and we will link that to our website so that you can kind of look at that. But I truly hope that we can begin to really make change. I think we've gotten several prescriptions, quote unquote, to kind of help us move forward. And sometimes it starts at the grassroots level. Sometimes it starts with you. Shaking up your organization, letting your curriculum committees know that we need more time before the patients to talk about pain and to talk about other issues that are important. So I encourage everyone that's on this call to do your part in your areas. Go back and listen to this, after it's posted, share it with your colleagues. But let's all do our part to make a change. And my committee members have also encouraged me to encourage all of you. This is off script now, to be sure to share your voices as we vote for as we prepare to get a new president of the University of Michigan. So attend the listening parties, not the listening parties, the listening session, fill out whatever surveys, but do your part to let your voices be heard. Don't assume that someone else is going to speak for you and to share the information that's on your heart. You be there to share your own story. So with that, we are going to wrap up. Thank you all again for coming. Thank you to our panelists. Give you a virtual applause for just taking the time out to be here with us and to educate our community about these very important topics. So with that, we will say so long. Wait, one more thing. Don't forget our final event are the book dialogues, which fit very well into some of the topics that we discussed here. There should be a link in the chat, and we will also follow up with you by email. So with that, have a great day, everyone. Thank you again. Best wishes.